Test, test.
Whitson. Carter.
Excuse me, ladies and gentlemen, we are calling to order. Thank you.
Present.
Sorry. Carter. Is not here. Okay. Hadsma.
Present.
Neely.
Here.
Glanville.
Present.
Kofia.
Here.
Conlon.
Here.
Farhat.
Here.
Fitzgerald.
Here.
Miller.
Here.
Reingans.
Present.
Vanderwall.
Present.
Filler.
Yes.
Mueller.
Here.
Van Workum.
Here.
Roth.
Here.
Schmaltz.
Here.
Thompson.
Present.
Representative Brenda Carter.
Present.
Madam Chair, you have 19 members present. You do have a quorum.
Thank you so much. Welcome back. It's been a couple weeks, and I just want to quickly say that my heart goes out to people who have had negative impacts from the storm. We are continuing to monitor the aftermath, but I am glad to see all our members are back and safe with us. I am excited to hear from our first presenter that we have today, Dr. Sarah Lyon-Callow, if you would like to come forward. She is Senior Deputy Director of Public Health Administration from MDHHS, the Michigan Department of Health and Human Services, joining us to discuss public health and the department's integral role in ensuring a healthy Michigan. Deputy Director Lyon-Callow, welcome to the House Health Policy Committee, and please begin when you're ready.
Thank you so much for that.
Wonderful welcome. All right. Good morning. I am the acting Senior Deputy Director for the Public Health Administration. I'm very grateful for the opportunity today to present on public health in our state and describe how the department contributes to our public health landscape. With the time I have today, I'll give a high-level overview of what public health is, how Michigan's public health system operates, and what makes us unique. I want to spend a little bit of time talking about the Public Health Administration. Sometimes I do call it PHA, but that is the group within the Michigan Department of Health and Human Services that has oversight for our state public health services. And then I'll conclude with an overview of how the Public Health Administration views public health measures through an equity lens. So what is public health exactly? When we think about the word health, we typically often associate it with medical matters. However, unlike the practice of medicine in a clinical setting, public health is not a one-on-one discipline. Public health works daily to keep people safe and healthy, and it works to understand and prevent disease in populations. Ultimately, it focuses on improving and protecting community health and well-being, with an emphasis on prevention among large groups of people. This is done by making use of scientific research and data and community feedback to identify population needs, by protecting against exposure to environmental and other hazards, and by ensuring people have up-to-date, accurate, and relevant health information to make conscious decisions about their lives and well-being. Our goal is most often prevention, to remove the chance that people can get sick. This goal is undertaken by working with other public entities and private partners. Fortunately, we have a wide range of tools and strategies to act into a strong public health system. We often refer to 10 public health services that help to explain the functions of public health to protect and promote health of all people. And that's what the circle figure represents. These services are arranged into 3 major components: assessment, policy development, and assurance. Assessment includes looking at the health of a community and investigating health hazards and root causes of health problems, then interpreting and sharing data with the community on a topic. The focal point for policy development is to use known data and evidence that were collected during assessment and develop policies to solve the health challenges of a community. Supporting and mobilizing community partnerships is an important part of the policy development process. Assurance involves public health agencies providing equitable access to public health services and programs that communities need. Overall, our responsibility as a department is making sure that we listen and help communities access the services and policies they need to build and maintain a healthy environment. Michigan's public health system is governed by the Michigan Public Health Code. State public health law and regulation are critical in granting authority, along with defining roles and responsibilities, to governmental public health system. Michigan has one of the most comprehensive codes in the nation. Under the Public Health Code, the Michigan Department of Health and Human Services is the state health department. The law requires that MDHHS endeavors continually and diligently to prevent disease, prolong life, and promote the public's health through organized programs. Additionally, MDHHS shall promote an adequate and appropriate system of local health services throughout the state and shall endeavor to develop and establish arrangements and procedures for effective coordination and integration of all public health services, including effective coordination between public and non-public entities. So what does this mean in terms of our duties, the duties of local health departments in your districts, and how we interact with organizations in what we call a public health ecosystem? So, Michigan has a governmental public health system, has a number of local health departments. So Michigan's Public Health Code provides the state health department and local health departments with co-equal or parallel duties to protect the public's health. As you can see on this map, the state of Michigan has 45 local health departments representing 1 city, 30 counties, and 14 multi-county districts. Local health departments are considered the primary entity responsible for the organization, coordination, and delivery of those public health services and programs at the local level. So we are constantly working together between the state and local health department. Local health departments aim to protect and improve the health of the communities they serve by preventing and controlling the spread of disease and injury, safeguarding against environmental threats, preparing for and responding to emergencies, and promoting healthy behaviors. Additional responsibilities include implementing and enforcing laws, utilizing health statistics for the purposes of protecting public's health, making investigations into the causes, prevention, and control of disease and epidemics, addressing environmental health hazards, nuisances, and sources of illness, and providing health education, nutrition services, among other functions. So the state and local governmental health agencies are one part of that public health ecosystem. The ecosystem also includes other state functions and other state agencies, like the Department of Education, managing hearing and vision screening for children, the Michigan Department of Agriculture with responsibilities for food protection, the Michigan Department of Environment, Great Lakes and Energy, which oversees public and private sewer and water supplies, and the Michigan Department of Licensing and Regulatory Affairs, which protects the health of individuals receiving care through licensed provider types. And local and state health departments work back and forth with those agencies all the time on those matters. We, of course, also coordinate activity with federal parts of the ecosystem with partners like the Centers for Disease Control and Prevention, the Food and Drug Administration, the Environmental Protection Agency, and other national agencies. We also work closely with the healthcare delivery system, hospitals, clinics, physicians and nurses, community health centers, and other groups to make sure communities have access to healthcare and preventative services. In addition, municipalities, businesses, employers, and academic institutions all play roles in assuring conditions for the public's health as part of that ecosystem. So I want to talk some about the Michigan Department of Health and Human Services Public Health Administration, which is responsible for a vast array of public health services and coordinates with the state's local health departments. The administration is composed of 5 bureaus, each with specific functions tied to public health services. For instance, the Bureau of Health and Wellness coordinates among internal programs, the public, healthcare providers, and community service systems to leverage resources and improve public health outcomes in the areas of chronic disease, injury control, maternal and child health programs. The Bureau of Epidemiology and Population Health includes environmental health public services, genomics and epidemiologic support, vital record administration and health statistics, as well as many other data surveillance systems that we use for understanding population health in the state. Our Bureau of Laboratories at MDHHS ranks 6th in the nation, and we're very eager to crack the top 5. The Bureau of Laboratories provides testing for public health programs, including testing of clinical and environmental specimens for communicable diseases, for human exposure to environmental threats. We also conduct testing for disorders of the newborn period. We'd like to thank the governor and the legislature for funding to build a state-of-the-art laboratory system, which MDHHS Bureau of Labs will be part of. This will help us to continue these services and be ready for the future. So thank you for that support. 2 more bureaus. The Bureau of HIV and STI programs focuses its efforts on the prevention, care, and treatment for HIV and sexually transmitted infections. They administer the Ryan White HIV/AIDS program for the state, and they also collect, analyze, and share data on HIV and sexually transmitted infections, and implement evidence-based programs and strategies to control HIV and STIs with public health and healthcare partners. And last but not least, the Bureau of Infectious Disease Prevention conducts and coordinates statewide communicable disease surveillance, response and prevention activities, and works to build and support the public health and local health department capacity needed to identify and respond to communicable diseases. In addition to managing the response to the COVID-19 pandemic, the Public Health Administration has achieved several accomplishments over the past few years. We're highlighting some of these activities in this slide. Last year, nearly 1.2 million children enrolled in Healthy Kids Dental, our statewide dental program that helps Michigan children under the age of 21 who are enrolled in Michigan Medicaid to have healthy smiles. We also saw almost 13,000 pregnant persons receiving dental care. We continue the fight against lead exposure, particularly in children. And among other activities, we were able to abate lead hazards in the homes of more than 1,300 individuals last year. The WIC nutrition program continues to be a necessary safety net for families. We had more than 1,200 mothers, babies, and children participating in the program. Our involvement in the Michigan Syringe Service Program has resulted in nearly 10 million syringes being distributed since October of 2018. This program has proven to reduce harms from substance abuse use to the individual and to communities, and to reconnect people to their community to make positive changes for their lives. Last year, the state laboratory and 4 regional labs that we were able to stand up during the pandemic completed 7.3 million tests for Michigan residents, ranging in subjects like genomic sequencing of tuberculosis bacterium, measuring and identifying toxins from harmful algal blooms that we identified in lakes in the state. And we also added a new screening test for spinal muscular atrophy to the state's newborn screening panel. We continue to use our Michigan Department of Health and Human Services strategic plan to guide our activities and objectives. One of those priorities is investment in public health by evaluating our funding sources for opportunities for innovation, efficiencies, and reallocation. This includes identifying gaps in local and state public health response to develop stronger and more sustainable mitigation strategies. Another priority is addressing racial equity and normalizing principles of racial diversity, equity, and inclusion across the Public Health Administration. So that includes continuing to evaluate our internal culture and our practices, and to evaluate how we interact with communities throughout the state. Where we grow, age, play, and learn all impact our health. Therefore, addressing food and nutrition, housing, and other social determinants of health is another one of our priorities as a department and within the Public Health Administration. In the state of Michigan, Black women die of pregnancy-related causes in 41 out of every 100,000 live births. This is in comparison to 51 deaths for every 100,000 live births occurring to white women. With this and other inequities or disparities identified, maternal infant health is a very important priority to PHA and the department. We're working to decrease barriers to prenatal care, investing in public health capacity, and providing health care access. Our department, local health departments, and other local partners offer programs for new moms and families, but we have opportunity to expand these resources, as you've seen in the governor's FY24 budget recommendations. As mentioned previously, environmental health, including reducing lead exposure in children, is one of our priorities related to public health. Michigan is one of the first states in the nation to be able to offer a lead prevention fund, filling a critical gap for homeowners and income property owners who do not qualify for Michigan Department of Health and Human Services abatement services. Actions such as expanding our lead abatement workforce, increasing lead hazard identification, and identifying variability in funding models to reduce lead hazards are important steps forward. So how do we measure progress in these and other areas of public health? I'm going to use an example from maternal and infant health to explain how we think about these measures. Racial disparities in maternal and infant health have persisted for decades despite continued advancements in medical care. In our state, the Black infant mortality rate is almost 3 times that rate for white infants. And for Black mothers, the severe maternal morbidity rate is almost double that for white mothers. Everyone deserves access to affordable, quality care and to feel like their concerns are heard during that care. So we might create interventions based on those experiences, and keeping the person at the center of those decisions. These interventions include information or programs that will be through one of our local partners. From there, we can evaluate progress by using measures like infant mortality rates, maternal morbidity measures, preterm birth percentage, and the number of sleep-related deaths. To ensure we close the gap on disparities, these measures must be disaggregated by race and ethnicity. This is one example, but all of our strategic pillars are tied to key measures that help us to monitor progress as we build a more equitable public health system and a healthier Michigan. You've heard me talk a fair amount about health equity in this visit here. So I want to talk about the role of equity in how we fulfill our public health obligations. Health equity is the state in which everyone has a fair and just opportunity to obtain their highest level of health. To achieve health equity, we must change systems and policies that have resulted in generational injustices that create a path for those disparities that I just described in terms of, for example, maternal health. Equity needs to be measured at each stage of a public health intervention, from development, implementation, in quality assessment, and in outcome evaluation. For example, this may include proposing policy changes that strengthens a community's resilience, may result in an equitable model for distribution of approved vaccines, or may target outreach to communities disproportionately impacted by public health threats. So all of this work happens thanks to the dedicated employees. At Michigan Department of Health and Human Services, there's nearly 15,000 employees. PHA, we're about 1,400 people that are working to promote those public health services. And we do have a presence in all Michigan counties. Very grateful to the Public Health Administration employees for the work they do on the behalf of the people and families of the state. I wish I could convey to you the dedication I see from this team every day. I'm also very grateful for the work and commitment of the staff at the 45 local health departments and in terms of their work for the health and well-being of Michigan residents. So if there's time, happy to take questions.
Is the legislative liaison for DHHS, so if individual members some questions or concerns, particularly that residents raised, she is a great partner. So thank you. We heard in our last health policy committee meeting about the disparities in the department's commitment to equity, which you thank you for the commitment to equity, which you mentioned earlier. Could you expound upon or kind of say some specific actions the department might be in the works on taking to reduce disparities in our state?
Sure. Sorry, having button troubles here. In terms of disparity reduction, I think a number of the initiatives that you are hearing about in other settings regarding healthy babies, healthy moms is a really great example of how we're working to using data to identify where those disparities are, and then thinking about creative models to allow for ways to get community voices into the process to help drive that programming. We are be happy to answer more specifics around other programs if that would be helpful. But in general, the expectation is that we are finding ways to measure those disparities. I think we've spent a lot of time measuring disparities in the department. When we're identifying those disparities, it's taking that step back to assess how are we making use of our available resources in terms of being able to move the needle on those differences and those disparities.
Thank you so much. And the other thing I would like you to touch on is we were in the first committee hearing, we talked a little bit about the Medicaid redetermination process that is starting April 1st. And I understand both DHHS and DIFS are working on some digital toolkits. Do you have a timeline that you have in mind for getting those out to the legislators? I think we're probably going to have a lot of our residents reaching out about questions.
I'm sorry, I do not have that answer for you, but we'll certainly work with Charday to help you get that answer.
Thank you. I'll take questions from other members. I think first we have Representative Hadsma.
Thank you, Chair Rogers. Deputy Director Lyon Callow. I heard a story coming in today about maternal mortality in Texas and how specifically down there the rates are very poor right now in terms of other states. How are we doing in Michigan? I don't expect you to know how we're doing in comparison to Texas, but how are we doing specifically in relation to maternal mortality? And in addition to measuring, what tools are we using to deal with that issue, and what tools aren't we using that we can adopt in relation to that issue?
Sure. Would be happy to share more detail about this in the future, but at a high level, maternal mortality in the state has declined over a great deal of time, but remains stagnant. And so we're not seeing continued declines in that mortality rate. And we are continuing to see large racial disparities in maternal mortality. We have, the state of Michigan has had a maternal mortality review since 1950 in partnership with the Michigan State Medical Society. We continue to conduct those reviews. And part of the reason I mention that is part of that activity is by investigating these deaths in more detail, we're able to identify places where there are holes in the system or there are policies that are counterproductive in terms of ensuring maternal well-being. So we make use of that kind of information as well as other information to, consider different policy changes. I think there's a lot that you'll see support for in the governor's budget proposals. For example, there is a program called AIM, which Michigan is one of the states in the nation that's participating in this program. So, for example, one of the things that's occurring there is working, and this is a program that's been going on for a while in the state, and we're seeking more support for it. But one of the things you'll see in that activity is working back and forth with hospitals to improve different kinds of safety bundles for medical care. And that's around protection or improving care for hemorrhage or sepsis or some of the things that we see impacting that maternal mortality rate. Also, the programs like Healthy Babies, Healthy Moms that we are seeking more support for is also ways that we are working to impact maternal well-being so that we are, as women are coming into their pregnancy or going throughout their pregnancy, that they're in the best situation they can be for a healthy outcome.
Thank you.
Representative Rankins?
Thank you, Chair. Thank you for being here, Dr. Lioncallo. As an alumnus of Michigan Department of Health and Human Services, where I was contracted as an employee from MPHI, which we'll be presenting next, it took me like a year to learn the organizational structure of the 14,000 person department. And I think it was just illustrated, for example, by a question about Medicaid being directed at the Deputy Director of Public Health Administration. Can you explain what are a few of the different administrations, and then what is the org structure of, there's the whole director, there's the buckets of major service areas and administration, yada, yada down the way. Because you mentioned a bunch of bureaus. It's very confusing if nobody has ever heard of this before. And then I have one other question, too.
Okay, thank you. And again, we'd be happy to provide more information as well. So I think if you figured out the entire structure in a year, that's very impressive. The Michigan Department of Health and Human Services, with Director Hertel at the helm, is made up of a number of different administrations. So the Public Health Administration is one of those. I think of it as Medical Services Administration still, but it has a new name, the Health Administration and Aging Services Administration with Farrah Hanley at the helm there. We have a Policy Administration with David Kanizik at the helm. So there are a number of different administrations. I think this is where Charday can be extremely helpful in terms of making sure that, we're all willing to take whatever questions are out there and make sure they get answered. But I think having Charday as that translator perhaps would be very helpful.
So my follow-up question is about syringe service programs. And so the reason I prefaced it with, am I even asking the right person? So you might not be able to answer this. I know that in Michigan we have some laws on the books around drug paraphernalia, and we do have some syringe service programs going in the state. Is there any other legislative activity that you see that we might be able to work on that could help change some of our state laws in order to help address the opioid epidemic or other current laws in our books or on our public health code that we might need to change to allow for folks to do better public health work in the community?
Yeah, so I apologize. I didn't come prepped for that kind of question today. I apologize. But we'll definitely come back. And I guess I would like to share, I think one of the things that is extremely important in terms of being good public health servant and good steward of the support that we've received from the legislature and from the taxpayers of Michigan is that we do maximize our efforts by working across. So, for example, many of the activities and programs we're doing, I work in the public health administration, but I spend a lot of my time with my Medicaid colleagues and my policy colleagues and others. So, thank you.
Thank you. Representative Roth?
Thank you, Chairwoman Rogers. Appreciate it, Doctor. Thank you for being here. I'm going to ask a little bit to be a little more defined. I know you collaborate with local health departments, obviously with the state health department. Is there a mechanism where you got a rogue health department or a health department that's doing something totally new and that you would like to adopt? How do you deal with that? How do you communicate with those?
Yeah, so we have, daily contact with local health departments at a variety of levels. So the Michigan Department of Health and Human Services does have a comprehensive agreement with local health departments where we're providing support to the health departments for different kinds of services. I think the Essential Local Public Health Services funding is an example of that. One of the reasons I was eager to talk about a public health ecosystem here today is that there's no one part of the ecosystem that has all the answers and all of the solutions, or even knows what all the problems is. And that's why it's very important that we're learning what works well in different communities. We have a very rich, heterogeneous state here in terms of the kinds of solutions that work in different areas. So we have regular meetings with the Michigan Association of Local Public Health, both through the health officer forums and other kinds of forums there. We have contractual arrangements where we are working back and forth on thinking about next ideas for program enhancements. We have some limited federal funding for Prevent Block Grant funds that we can use for innovative models, like trying things out together. A lot of my experience, because I spent a lot of my career in Bureau of Epidemiology and Bureau of Infectious Disease, a lot of my experience with local health departments has been working back and forth on particular outbreaks. So, for example, when we had the community level outbreaks of hepatitis A among adults in Michigan, we're definitely not a top-down system where someone like myself, Dr. Lyons or Sarah Lyon-Callow says X. It is very much a collaborative system back and forth. We have protocols that we know we want to follow in a communicable disease outbreak, but how the rubber meets the road and what the right ways of communicating the right solutions for these kind of investigations really occurs at that local level. Thank you.
Appreciate it.
Representative Thompson.
Yes, thank you, Madam Chair. Thank you so much for your presentation. So I have a question. I would like to go back to where you talked about public health administration and the WIC program, Women, Infants, and Children. Is this an error, or right here I see each day 1,200 moms and babies? Did you mean that doesn't mean per day? Does that mean per day? Or what is the total number of women that are involved with the WIC program? And then I do have a really quick second question after that. So how many women in Michigan right now are currently served under the WIC program?
I will follow back with the exact number there. Thank you for calling
And
that out.
then with regards to the WIC program, when we discuss the disparities that we're seeing in the mortality rates with the maternal care of moms and babies, what is MDHS doing currently to promote breastfeeding within the WIC program, and what does that look like within the MDHS and the WIC program? And that's actually the last question. Thank you.
Thank you. I am not prepped to tell you all the detail about what WIC does in terms of breastfeeding today. I apologize for that. Okay. Be happy to provide more of that information back. But I know that is a very important aspect of WIC is providing, I know there are services that are provided or available to women enrolled in the WIC program to increase support for breastfeeding, but I would need to get you more detail about that. Thank you.
I think we're going to have time for one or two more questions. Representative Carter.
Thank you, Madam Chair. And thank you for your presentation. I would like to just read a brief portion of a resolution that I wrote in 2019, House Resolution 123. Whereas the country with the highest mortality death rate in the developed world, the U.S. lags behind many other countries. The U.S. also struggles with persistent racial disparities. Black mothers in U.S. die 3 to 4 times the rate of whites. Here is my statement and my question. Statement. I'm really glad to hear that the mortality rate in Michigan is declining. Question. Are the rates for black women in Michigan declining?
So I want to be clear that when we look over decades, we've seen a decline in the maternal mortality rates, but recently they are stagnating in terms of decline. And what we have seen is a persistent disparity in the rates between white mothers and black mothers in terms of maternal mortality. And that, reducing that disparity, we have that disparity has been persistent over time.
Point of clarity on that, then, are you stating that there has not been a decline in maternal mortality in the Black community with Black women?
So there has been, over a longer period of time, there has been a decline in the rate among Black women. But what I'm saying is that the relative difference in the rate between whites and Blacks has not declined over time.
Thank you.
And Representative Conlon, and then we do have another presentation.
Thank you, Madam Chair, and I'll be brief. I'm just wondering how much, given the racial inequity issues, how much do you all partner with grassroots advocacy groups like Mothering Justice in Detroit, which is a midwifery movement, or Real Michigan, which is the recovery community's opioid addiction grassroots program? Do you get a chance to work with them and share resources?
So, again, we'd be more than excited to come back and talk more about this particular issue in terms of maternal health and infant mortality. We have invested in a group. Sorry, I'm trying to look at you while speaking in the mic at the same time. We've invested in a perinatal coalition model in the state, and those kinds of organizations are able to participate in those coalitions and through that collaboration. So,
Thank you. We really appreciate your time this morning and lots of great questions from committee members, a lot of interest. Up next, we have a presentation from Dr. Renee Branch Kennedy, CEO of the Michigan Public Health Institute, and she will be speaking to us about a topic that has huge impact on many of our communities, including mine, social determinants of health and equity. Thank you and welcome.
Thank you, Madam Chair. I'm so pleased that weather delay and session delays did not preclude my opportunity to speak with you today. So I am going to just be a bit iterative on some of the points that Dr. Lyon-Callow has made before you, and just give you a little more context in terms of my role and our role. Just a little bit about me. I am a medical sociologist by training and a 30-plus year public health professional, including having served as the health officer for the Ingham County Health Department. So I appreciate the question about local public health. I've been honored to lead the Michigan Public Health Institute for the last 9 years. And let me just start by telling you a little bit about who we are. And it is continually interesting and a point of innovation to me that the Michigan legislature in 1989 said we need to create a mechanism for supporting state government public health. And so with that creativity and thinking about how do we bring together academic public health, governmental public health, and community, those of you that have made comments about community, how do we bring together a space that's safe, honest, and an opportunity for dialogue across difference, I would say. And so we have been created in statute as a purpose to empower and advance the health of Michiganders. We like to describe ourselves as a Michigan-based and nationally engaged nonprofit. Much of the innovation that we're able to bring to our state and to our partners at the State Health Department, MDHHS, are due to connecting and hearing and learning about what's happening in Iowa or Wisconsin or California. And we bring that back and think about how it might apply. We also are a conduit in the opposite direction, where Michigan has had some deep successes, and we can also work to make our nation a better place because of the assets that we bring in Michigan. So we are a nonprofit by nature. We are government. Our proximity to government is unquestionable. I say all the time that public health is governmental, and what the rest of us do in nonprofit and community space helps advance the muscle of who keeps us safe. We learned that having experienced a 100-year pandemic as those that experienced others in the past. But that commitment to governmental public health is demonstrated, I think, in our core values. We have, one, a commitment to quality and excellence. Why bother doing anything if it's questioned? We do it well. We are committed to relationships. I describe myself as a relationship-driven leader. My job is easy because, as I said, I had 30 years of relationships to bring to this space. Dr. Lyon-Callow mentioned servant leadership and public service. We are that as well as committed to health equity and social justice. That's quite all right. Technology. It's quite all right. You know, and I mentioned that I'm a sociologist, so I really want to give you just some big picture context for shaping your thinking as you do the deep work of policymaking for this state. You know, in general, the United States is a fairly and a comparatively unhealthy country. When we look at how we compare to all the other developed nations, one example, the U.S. ranks at about 35. Our health as a nation is worse than places like Lebanon and South Korea and Greece and Cuba. Our metrics of health are poor. And so you have to wonder, given that we are truly land of the free, home of the brave, one of the most influential nations in this world, and I grew up as the daughter of a career serviceman, what is it that we're missing? And this is not exclusively an issue of race. If white America were its own country, it would rank 34 nationally. If Black America was its own country, it would rank 96. And so our request of you, as your constituents, is to think about what we begin to do to chip away at those types of metrics. And we're all sort of socialized to think about health in these sort of four Hollywood squares, right? Eat a healthy diet, get your exercise. We got real progressive and said, oh, sleep deprivation is a thing. We better make sure we're getting enough sleep. And be sure you're seeing your physician. Know your numbers, check your numbers. Well, we also know from a public health lens that health is way, way more than that. And so in public health, our mission is to assure the conditions needed for good health. So those conditions might be, what is the walk home from school like? In some communities, it is beautiful and manicured and safe. And in other communities, in Michigan, it is riddled with threats and broken glass, and you're gonna trip and fall on your way home. What does the view from your backyard look like? These are the conditions that we are concerned about. Is it beautiful? You hear birds singing, or is it a reminder that there are maybe toxins in your outdoor air quality and your indoor quality? What is your work environment? We are just now in the month of women. And someone asked me about the year of the women, the month of women. So I put this in here to highlight that both men and women have varying context for how we live our work life. Some of it is stress because of the tension of administering high-stake programs. Others of it is just the stress of repetition and performance. And how do we look at those differences? What does our community look like? We learned during the COVID pandemic when we said, oh, just go home and quarantine. Something that seemed simple was not simple. When you're in a multi-generational home, as opposed to a large home where everybody can be in their own room and you're not on top of each other. So these, again, conditions make a big difference. What are our schools like? I really am challenged by this because I think it speaks to your power and authority as legislators and as policymakers. That lower picture, well, at the top is a beautiful modern school, LEED certified. Sure, they have all the beautiful technology that doesn't challenge them in the middle of classrooms and meetings. How do you do that? And then the one at the bottom is an actual picture of a school that was built next to the county jail. What policymaker would think that is a good idea? And I would offer that it's kind of hard to even determine which is the jail and which is the school. And so the decisions and the context of your decisions matters. And so we've been talking a lot as of late about how do we get our decisions upstream as opposed to downstream. And Rachel Milani Chan talks about downstream as the tendency that we have as individuals and as decision makers to focus on kind of one-off, individual lifestyle-based, short-term solutions rather than the long-term interventions that really address the root cause of well-being. The why behind the why. Well, why is that? Why is that? Why is that? So that we're at a space where we really can address the conditions for good health. Dr. Lyon-Callow shared with you that definition of health equity, which is the state in which everyone has a fair and a just opportunity for being their healthiest self. And so that requires us now to think about, given the statistics that you just heard about maternal health and about infant mortality and about heart disease and kidney disease, pretty much every metric of morbidity and mortality is going to see white Americans, white Michiganders faring better, and black and brown Michiganders faring worse. What is that, and why is that, other than those individual-based contexts? And so as we think about getting upstream, I want to just offer sort of a few reframes of very traditional public health questions. Why do people smoke? We in public health advocate that smoking is hazardous to your health. And so instead of just saying, don't smoke, we want to begin thinking about, well, why is it people are smoking? And why is it particular communities have higher rates of smoking? Particular populations have higher rates of smoking? Maybe we should also ask, what are the social conditions, the economic policies that are predisposing people to the stress that causes them to then reach for that cigarette? That's an upstream question. Another one, who lacks access to healthy food options and why? Hunger remains an issue. You heard the information about WIC. Why is WIC a necessary service? Because hunger and nutrition remains a challenge in our state and in our nation. And so we also push that maybe what we should be asking is what economic shifts would redistribute healthy food resources more equitably in our communities. And I would offer, sometimes I get pushed back on redistribution questions, but we're simply saying that if we have a pie and we say everybody has to have pie, but some people say, I actually don't like pie and I don't want pie, give my pie to them. That we give ourselves permission to meet people at the point of their need instead of sort of the arbitrary, unilaterally treating people the same. Let's treat people based on what they need. A couple more. How do we connect individuals to cancer screening and support? Well, what are the institutional policies and practices that counteract people's access to screening and support? Thinking about that. This last one I want to particularly say because it's a demonstration of your success in your policy making. Who lacks health care coverage and why? Well, we asked what policy changes would redistribute healthcare resources more equitably in our community. The Healthy Michigan Plan did just that. But that was decision making and grappling and thinking and arguing and reasoning together. But we see that change can and absolutely does happen. We are still in a place where we have to disrupt the historical legacy of things like racism and gender bias and economic disadvantage. Those things are still impacting us, whether intentionally or not. The consequences remain. So I would suggest that we got close to the finish line with civil rights efforts, and it's now our responsibility to carry this over the finish line. How do we make sure truly that everyone has the opportunity to be their healthy self? How do we think about powerlessness and poverty and the things that get in the way of people being their healthy self? The choices people make are determined by the choices people have. And how do you, from your legislative stance, make sure that for Michiganders, the healthy choice is the easy choice? And please know that when we were created by your predecessors several decades ago, it was to do just that, support you in making sure that Michiganders are healthy. Thank you.
Thank you so much, Dr. Kennedy. And I really appreciate you highlighting healthy eating. I was actually recently, I wish this particular stakeholder was still in the room, but I was recently eating a meal and highly encouraged him to eat his greens. And he pushed back a little bit, but because I am the health policy chair, I strongly encouraged him, and he was able to sample some salad. With that, I have Representative Carter that has a question.
Not a question. Thank you, Dr. Kennedy. I just want you to know that the apple didn't fall too far from the tree. I know your entire family and your mother-in-law is the reason I joined Delta Sigma Theta, Hortense Kennedy.
Thank you so much.
You're welcome.
Love her.
Me
forever.
too. Me too.
Thank you.
Vice Chair Vanderwall.
Thank you, Madam Chair, and thank you for being here. You got me all excited when you started off the sentence with steak, and then you added holder. I don't know. I thought we were ready to go to dinner. So, but real quick, as we talk a little bit about poverty in the mortality rate, I know that in some areas we've put maternity coaches out, and they've helped in those districts. Can you tell me, do you have any results or any data that shows that we're providing better outcomes during pregnancy? And if so, how do we really start to move forward and bring this program statewide?
Mm-hmm. The community health workers are an absolute model that's been effective not only for maternal health, but for lots of health. It actually started around cancer care and helping people manage this very complex system of care. And then we began doing more things around nutrition, around other access. So in many spaces, we're just at the place where measurement is happening. This partnership between governmental public health and academic public health that we support is really, really important, because the scholars who are spending their time doing the measuring is then what helps inform the policy recommendations, the programmatic recommendations. There is a new initiative, not completely new, but Birth Detroit in Detroit is a nurse-led, midwife-led initiative to support moms in having healthy births. And their initial outcomes, just in doing childbirth classes, has been phenomenal. So we'll be looking forward to supporting and the collecting of data around empirical findings, in addition to the anecdotal stories we're getting.
Thank you. I appreciate that. And you bring up an interesting, when we talk about midwives, and we're starting to see, especially in, the inner cities, in our rural areas with the loss of OB. Is there data that shows that we're having successful births deliveries, or is there an increased risk with a trained midwife? And what do we need to do looking forward to trying to, again, in the rural communities, to bring back more care?
I absolutely believe that what we call mid-level providers, midwives, although they may not want to be called that as I just say that, but physician assistants are absolutely making a difference in those spaces. As I mentioned, we're at an interesting historical place where many of the interventions are still early on, and so as they're collecting the data to begin to tell the story, we'll be watching that closely. But absolutely, access is both an urban core matter and a rural matter, and solutions can be complementary.
Thank you.
Mm-hmm. Representative Kafia. Representative Glanville.
Thank you, Madam Chair. Not so much a question as a comment, Dr. Kennedy. Thank you so much for bringing this presentation forward, and I hope that you have the opportunity to present with other committees here. I've had a pretty intense experience with nonprofit and learned quite deeply about the SDOHs at that time, and I'm really pleased to see this coming to the surface. I'm from the Grand Rapids area, and the Grand Rapids Chamber of Commerce does an annual policy conference. The entire theme was on SDOHs because they are beginning to understand that if we do not take care of people, where's our workforce, how are we moving forward in all of these other areas, and that the social determinants of health are really the foundational piece that we need to be focusing on. So thank you for your work, and thank you for sharing that with us today, and I hope our colleagues can kind of keep this in mind as we go about all of our work here at the state.
Yeah, the work in Grand Rapids has been absolutely exemplary. They have a phenomenal local health department there as well. And so thank you for that. Dr. Lyon-Callow, I think, used that definition of where we live, work, play, pray, age. We've just continued to add more settings in that. So thank you for sharing that.
And Representative Reinkens will close us out.
Thank you. Thank you so much for being here, Dr. Kennedy. I've heard a lot of questions today about the big disparity in maternal outcomes. And I want to tie it back to your presentation where you went through a series of slides that talked about the different kinds of conditions we can be in. And one thing we didn't really talk a lot about today related to maternal mortality disparities is that it's not just individual interventions with the mother or the birthing person. It is all the things that are around them and support them as they are pregnant, gestating, birthing, and then recovering for more than just like a couple weeks, right? There's a longer recovery. So there's all these conditions that impact the individual person's health, including the stress of experiencing sexism, racism, and other structural barriers. And so I'm hoping that you and maybe others could come back and we could have a committee hearing specifically on the maternal health disparities and bring in some of the research that is even happening here at our research institutions in the state, talking about some of those factors that contribute to the poor maternal outcomes. It's not just whether or not somebody has a doctor. There's many, many factors stressing the individual bodies of people who are birthing. And so that's tied to how you were explaining the many factors that impact our health. So stay tuned.
Thank you for that. I cannot tell you how many Black women I know that have had what we're now calling near-miss experiences. My own personal experience of delivering my first son at 28 weeks and then losing him 6 months later due to RSV, which so many of us have now heard of, I had every resource available to me. And so we're beginning to understand there is something about the stress of racism, even when we think we're handling it well, that is undermining our ability to live healthy lives. And I just have the audacity to believe that we're at a point now that we're saying enough is enough, and good enough is not good enough. We're going to make sure everyone can be healthy in this country. So thank you. The maternal health matter is deeply personal and deeply complicated, and thank you for attending to how important that is.
Again, Dr. Kennedy, thank you for sharing your personal story and this important information, and I appreciate everyone's questions. There being no further business before the committee, we will stand adjourned.